It's my great honor and pleasure to welcome you all to this inaugural Healthcare Ethics Symposium, the first that the Markkula Center hosts. This academic year has been very special. It has seen the return of the in-person class. It has also seen the return of the first-hand clinical experience that we have missed so much since the pandemic. And it has also offered our brilliant students the opportunity to reflect on ethical challenges and discuss them in class with our many guest speakers. Last but not least, it has offered them the opportunity to write about a topic in bioethics that is close to their heart and to be published on the Markkula Center website. Today, each one of my interns, but also my Honzel fellow, Mary Francis here, will present the ethical dilemma that matters the most to them and their ideas on how to tackle it to help our community, our country, and the world. For the tremendous work they did in writing about their issue, but also in preparing for this conference, I would like to ask you to join me in a round of applause for them. Please help me welcome Mary Francis Garcia, my Honzel fellow.
Okay, hello everyone. This is me. For those of you that don't know me, hello. My name is Mary Francis Garcia. I'm a Honzel fellow. I'm a neuroscience major with a biotech minor, and I'm a senior. And I'm here to talk about what I've been working on all year. And that's a manuscript with the title as follows: More Than a Digital Twin, a Digital You, an Embedded Ethics Approach for the Future of AI-Driven Medical Decision Predictors. So first I asked that you entertain a scenario for me. A man suffering a car accident has been rushed to the hospital under life-threatening conditions. In the emergency room, of course, he is treated for his immediate physical injuries, but has entered a vegetative state. The hospital calls his wife, who up until then had been living a pretty normal life, never really had the chance to really be kind of immersed in the hospital environment. But they call her up and they tell her that her husband has been in an accident and he's in a vegetative state. He can no longer make medical decisions for himself, so she must be that person. She is now his surrogate decision maker. Now, this is a situation that I'm sure has happened many times over. A family, a spouse's life has been turned upside down by the injury of a family member and is thrown into the world of surrogate decision making, sometimes without having a clue what to do. So let's talk about surrogate decision making. What is it? When a patient is deemed without capacity to make decisions for themselves, whether it be because of mental illness, cognitive decline, or even being unconscious, a surrogate decision maker is appointed. People that can be surrogate decision makers are someone with the power of attorney, which is most likely a family member or a spouse. But in the cases that these aren't found or are unavailable, an ethics committee comes together, and this is a committee of many perspectives within healthcare, be it doctors, chaplains, bioethicists, community members. The idea is that this is a committee of very diverse perspectives. They come together and they can, one, they can make decisions for that patient, or two, they can seek out and acquire a court-appointed surrogate decision maker for the patient. Now, how do they make decisions? So when surrogate decision makers make decisions, they use what's called substituted judgment. And that, in a nutshell, is what the surrogate thinks the patient wants. But I have some concerns about this. The first one being respect for autonomy about the incapacitated patient. As I said before, they use substituted judgment. That's what they think the patient wants, not exactly what they want. And for the most part, I do believe that surrogates do their best to really carry this out in a way that's true to the patient's wishes, but my worry is about things like competing factors, such as what if there's a large sum of money involved with the patient passing away. And because of similar kind of things that might be, a phenomenon, then there might be some sort of disjunction between what the patient wants and what the surrogate wants. So I do worry about the patient in that way. But on the side of the surrogate decision makers and looking out for them, while many surrogate decision makers think of the process as very fulfilling and rewarding, there is the side where the process can be very much an emotional burden for them. There's this thing called post-intensive care syndrome, where family members and even the patients themselves and surrogate decision makers have exhibited PTSD symptoms after a family member has been in the ICU, for example. So now thinking about all of this, I've been chewing on the question of how can we remedy these concerns while keeping the patient's actual morals and values at the center. So what better way to do that than technology, given where we are in the state of this era? So I came up with this proposed conceptual model of the digital you. And it's made of the concepts of digital twin and generative AI. Now we're going to go through and build this model together to kind of give you an idea of where I got this idea and how I built it in my own head, and then we'll get into actually how it would work. I will put the disclaimer now that this is not real. This is simply my own little brain baby. But as I said, kind of given where technology is and where it's going, I could very much see this happening in the future. So first, we have the digital twin side of things. So the digital twin was proposed in 2003 by Michael Greaves. And up until then, it didn't really have a place in healthcare. It was really used in things like aerospace, military, and industry. And it's kind of exactly what you think. It's a virtual version of some sort of physical entity and mimics it in the 4 dimensions: geometry, physics, behavior, and rule. And as I said pretty recently, this concept has been kind of taken into healthcare, wherein people have proposed the idea of creating the digital version of a patient. So that way we can use the virtual patient to, say, test treatments, test drugs on them without ever having touched the patient. And in this way, we're making huge strides towards personalized healthcare. Now moving on to the second part of it, the part of generative AI. This is the part that I was really going to get at the subjective side of a medical decision. We're very familiar with ChatGPT, which is a form of generative AI that uses 175 billion information parameters to come up with a response that it gives when prompted through input. And what's really interesting about ChatGPT, as a lot of us know, is that it's like you're emailing a friend. It's very personal. Now, generative AI and its ability to be able to make real inferences about someone based on information it knows about them might seem far away, but maybe it's a little bit closer than we think. There's research at Stanford that recently found that the most recent iteration of ChatGPT 4 can perform similar theory of mind abilities to a 7-year-old by answering 95% true-false theory of mind assessment. And theory of mind, as we may or may not know, is kind of the ability of someone to know what you're thinking in a certain situation. So putting this together, finally at the point of like, what is the digital you and how does it work? So in a nutshell, the digital you would be an AI algorithm that is a digital version of your entirety, your genotype, your phenotype, and most importantly, your personality. The first 2 parts of that is going to be taken care of with the whole digital twin aspect. It would be you in your physiological state, your pathological state. It would also have data on things like medical research. But then it came down to how are we supposed to get to someone's personality? I feel like the best way to do that would obviously be to be able to decode the signals in your brain, but I think that's a little too far-fetched for me. So my next best idea was that the next way that this could be done is through conversations. So like we might be able to get at someone's personality through the conversations they have and the interactions they have with other people. So how is it going to do this? The idea behind this kind of being a thing is that the digital you would have a physical component that would be on your person at all times. They'll essentially listen to your conversations 24/7. And through the information it gathers based on the interactions you have with people and the conversations you have, it would be able to deduce and kind of filter that information out so that we can get to your morals, your values, your healthcare decision-making habits, and what really is of meaning to you. Now, this all going to sound really, really confusing, so I apologize, but I think it'll be better if I put it into context of how we can use it. So now we're back at the first scenario that I brought up earlier. This is a man that's gone to a car accident. He goes to the emergency room. He gets treated for his physical conditions. But now he's in a vegetative state. Using the digital you, the care team could then access that AI algorithm. There's some special credentials, put in some treatment options, and then the digital you, using the information it has based on their current physiological state, their medical history, other medical history from the population, medical research, and including all the data that it's gotten on their personality, it would be able to make a decision for that patient, just as that patient would have made that decision itself. Now, with this type of technology, I do see a couple pearls and a couple pitfalls. The first pearl is that I do believe that this would artificially conserve autonomy. As I've said, this is something that would make a decision just as you were making that decision. And in that way, we're kind of keeping what the patient would want as that medical decision as that, no questions asked. Another problem is that it would be an up-to-date advanced directive. A lot of people in this country don't even have an advanced directive, and even if they do have one, it's really old or very outdated and not really at all what the patient would want. Having a digital review would make sure that someone's advanced directive is always up to date and always accurate. Next, kind of going back to what the benefits of a digital twin are, it could be very helpful for personalized healthcare. And then lastly, any pressure of the emotional burden from surrogate decision-making on the surrogate decision-makers would be avoided and taken out of the picture. Now, some pitfalls regarding this technology. The first of all, always bias when we're talking about AI. AI has to be made by people, and people have bias, and that could always get perpetuated through technology. And then there's reliability and the right decision. Ideally, we want this technology to make the right decision in terms of a healthcare decision. And if it doesn't, then the patient's life is obviously immediately at risk. Next is our threat to privacy. Conversations you have are not just between you and yourself. Conversations are between you and another person, and that person can disclose really personal things or really private things. So, and also the companies that is going to make the digital you, they can also have this data, and you don't know where it's going to go or what they're going to do with it. And as I said, it's not just your own data, it'll be the data of everyone you talk with. Next is whether the DUI could have full autonomy. Because, as I said, this could artificially conserve autonomy. Does that mean that whatever decision the DUI makes is the decision that the doctors go with, or should it be the decision that the surrogate goes with, especially in the case that there's a lot of disjunction between what the DUI says and what the surrogate says? That's a conversation that would need to be had for sure. And then lastly, AI is not rational as far as I've read. As we see, the people that we appoint as surrogate decision makers they are people and they are humans and they are rational, and those are the people that we've trusted to make those decisions. AI, at least as it stands, has not been discussed to be rational, and therefore might not be able to really, have full autonomy in that sense and be able to be a trusted source for a medical decision like that. So this is all kind of getting at what I'm kind of advocating for in this scenario. As I've said, the DUI is not a real thing, but should any iteration of it be made, I do believe it should be made with the embedded ethics approach. So the embedded ethics program is actually something that was launched at Harvard really recently. It's to bring ethical reasoning into the computer science curriculum, which in other words is just they're giving computer science students philosophy and ethics classes to make them more ethical scholars. But this theory has been adapted to AI in healthcare, wherein when we're creating AI, it should be a collaborative effort between programmers, software engineers, physicians, and most importantly, bioethicists and ethicists. That way, all of the pitfalls and the concerns I've had in the last slide are going to be addressed, and the benefits of this type of technology are maximized. This is especially important because there's not a lot of regulation on generative AI because it's so new. But in the meantime, while those regulations are being developed and implemented, it's our duty as a society to make sure that when we're creating AI, we're creating it consciously and responsibly. Thank you.
Thank you, Mary Frances. So our next speaker is Oriel. Please, Oriel.
Hi, I'm Oriel Zagazeta. I'm a junior and I'm a biology major with a chemistry minor. And today we're going to be talking about stem cell use and research in healthcare and the bioethical perspective of this. So first, what are stem cells? So stem cells are normally found cells in your body. They're also found in embryonic development that have the unique ability to differentiate into any other cell types. They could turn into neurons, they could turn into liver cells, skin cells, you name it, and they can turn into it. And they have really unique use in research and healthcare because we don't exactly know how this process works, and we don't know the full capabilities of them. So let's take a look at it a little bit deeper. So there's three main sources that we can get. Like I said before, there's some that are in your body, and there's some during normal human development in the embryos, and then there's another one that I'll talk about in a little bit. So embryonic stem cells. How are we going to source these for research and healthcare? So to prepare for in vitro fertilization, couples usually create 5 to 9 embryos and store them cryogenically for later use in pregnancy. But the problem is that not all of these will be actually implemented into the mother, and not all of them will be used. Some of them might be stored indefinitely in cryogenic chambers. Now, the parents do have the option to either discard these later on or donate them to stem cell research. And this has been the main source for stem cell research in the past. However, there are a little bit of ethical issues, controversies, especially with Roe v. Wade that's been overturned recently. So this isn't really as preferred of a source to source stem cells. Another way to source stem cells is from donors, and you may know this commonly from bone marrow donation. Other ways to source this are from umbilical cords after pregnancies, after birth. But the problem is that if you're going to donate these source stem cells into a patient, you need to do histocompatibility matches so that they have to have the same blood type, they have to have the same cellular signaling markers, all of these factors that come into play. And it's hard to find a good match, considering that also most of these are from volunteers, volunteer donors, and they have to be on a registry. So that also comes into issues with informed consent of the donor. Where are these stem cells going to be going? Are they going to be donating specifically to a patient or only to research? Another thing is that this procedure requires general anesthesia, and with that comes any risks to the donor, so they have to be informed of that. Another way that we could sidestep this, though, is be using these induced pluripotent stem cells, which is a fairly new research that's come up, and it has the unique ability to take any living somatic cell from a patient and use these 4 transcription factors that you see, these ones, and you can actually reprogram this living somatic cell into an induced pluripotent stem cell. And this has the same ability as embryonic or donor source stem cells to differentiate into any type of other cell in the body. And this is great because you don't have to worry about blood type, you don't have to worry about these other cell signaling markers that I was talking about earlier. It actually has the patient's own DNA, so this is an autologous transplant into the patient, which is awesome. But there are some pros and cons. So some recent research has shown that you can actually use these iPSCs and you can create human organs inside of pigs, which is really, really quite unique. And you can have it with the patient's own DNA. So this is going to be really great for human organ transplantation, right? So they can remove donation and all of that type of stuff and give a lot of more organs available for people. We've also had the ability to restore vision, as you see in the bottom left. This person has macular degeneration. We've been able to restore it so they're able to see again. So obviously there's great claims of beneficence for the patient when we talk about our ethical principles here. And in the middle we have a neural network that's actually created from iPSCs. And this is kind of going into the realm of, what is actually good, what is actually bad to do? Because what if this forms consciousness? How are we going to relate that to ethics and say, like, okay, how are we going to give this rights or not? So that kind of gets in a gray area. But kind of problems with iPSC use is that in the bottom right you see like there's some studies that have linked iPSC use to cancer. So that can be, challenging non-maleficence. So you have to kind of balance these 2 ethical principles. Okay, maybe we can restore function in these patients for blindness or there's other neurological problems that you can solve, but at the risk of cancer. So you have to kind of weigh with the patient, talk with the patient and see, okay, what's the right option for you? And finally, as you can see in the top right, there's with these new studies going all around the world, there's been this new era of stem cell tourism where people travel to other countries which don't have as strict laws on this type of use in healthcare, in search of cures for blindness that aren't actually yet discovered. Currently in the U.S., the only FDA-approved stem cell therapy is for blood-forming stem cells, as you see with bone marrow donation. But it hasn't been approved for anything else. So what we should really do next is continue our research with stem cells so that we can fully understand the consequences and the benefits of both sides, so that we can prevent any harm happening to any patients and understand the full implications. Thank you.
Hi everyone, my name is Shelby, and I'm a senior studying biology and public health science. And today I will be talking about fertility tourism and what you should know before you go. So about 1 in every 6 people of reproductive age experience some sort of infertility issue worldwide. Fortunately, though, there are medical treatment options available for these individuals and couples, such as IVF, egg and sperm donations, and even surrogacy. However, for various reasons, these individuals may not be able to access these medical treatment options in their own country, so they opt to travel abroad, and this practice is what we call fertility tourism. So the main 2 reasons that a couple or an individual may opt to do fertility tourism is either for cost or home country legislation reasons. So as for cost, as we know, these medical treatment options can be fairly expensive. In the U.S., in single rounds of IVF can range anywhere from $15,000 to $30,000 as of 2023. Other countries, though, such as Mexico, have fertility clinics that advertise this same treatment for just $8,000. So that kind of significant price difference may motivate others to travel abroad. As for home country legislation, as Oriel previously mentioned, different countries have different policies pertaining to medical treatment options. For example, Canada bans all forms of surrogacy, whereas here in the US, there's no federal regulation regarding surrogacy at all. So we are a popular option for that. Abroad, in Europe, about 16 countries ban access to artificial insemination for single women, and that number increases to 25 countries that ban access to artificial insemination for lesbian couples. So for those countries, more lenient options such as Denmark and Czechia are popular because they have more lenient policies, but still they have high success rates. Although this does seem like a fairly good option for these couples and individuals, there are some ethical considerations that we should examine before accepting this complex medical trend. First one is from the patient perspective. A lot of the travel can be very taxing for the patient, and due to the accelerated process, this can put the patient at greater risk of health complications. The patient may have to fly between their home and their destination for cost reasons, for work, and this can put additional strain on the patient that may be critical for the embryo's well-being. We must also consider why the patient is going abroad. As I previously mentioned, cost, legislation, but some couples also seek to go abroad for gender selection purposes, and this is where we kind of enter like some murky water. Ever since the inception of genetic screening for gender, it's been debated over whether this practice is ethical or not, because if we widely accept gender selection, this could lead to a slippery slope of acceptance into other discriminatory problems associated with embryo selection. From the provider's perspective, their main concern here is informed consent, especially since you may be traveling to a country where you don't necessarily know the native language. It's really important that the provider provide the explanation associated like risks, complications that may be associated with the procedure in a way that the patient understands. And lastly, for the destination country, a report out of Czechia hints that the influx of patients coming from out of the country can increase prices for these treatments for people all in the country. So this kind of raises the question in the principle of fairness over whether people coming from outside of the country should take precedence over the nation's citizens just because they have the financial means to do so. In addition, it's important that we take into consideration who is providing services in these destination countries. Because it's cheaper, that might mean that women in these countries, especially vulnerable women from like lower socioeconomic statuses, don't feel that financial pressure to submit their bodies to these treatments just because of the financial reward that they might be receiving, especially in cases of surrogacy or even egg donation. So it's really important that we respect the patient's autonomy in these situations and take into account the potential coercion that they may be experiencing. Overall, it's a very complex medical trend that's up and coming, so it's really important for policymakers and honestly just any stakeholder involved to take into consideration these factors. I suggest that rather than trying to tackle these complex fertility problems and overpriced treatments, we attack them at the root cause rather than trying to send people to other countries and put the patient at greater risk. So I think if we do this, then that'll lead to greater patient outcomes and more equitable access to care. Thank you.
Hi everyone, my name is Lexi McGowan. I am a senior in biology and public health double major with a minor in chemistry. Before we start, I've been a little sick, so I'm sorry if I start coughing or if my voice goes out. But moving forward, my topic is on how delaying gender-affirming care until adulthood is unethical. So starting off, gender dysphoria occurs when there is a misalignment between one's experienced gender and the gender that they are assigned at birth. This can lead to a variety of issues, including stigmatization, lack of ability to form social connections, anxiety and depression, which can ultimately all lead to much more serious consequences in the future. There are 4 main steps that we can take to combat gender dysphoria, and complete transitioning. The first of which is a social transition. This may include things like changing a name, possibly changing pronouns, changing the way one dresses. It can look a little bit different for everybody. The second step is puberty suppressants, which essentially halt the development of secondary sexual characteristics and allow extra time for cognitive development and exploring gender before we move forward. The third step is cross-sex hormones. These are partially reversible, and they essentially allow for the development of physical characteristics that are more in alignment with one's gender identity. And finally, there are gender-affirming surgery, which is completely irreversible, which includes the modifying, reconstructing, removing of genitalia to allow people to be more in alignment with their gender. All of these things have shown significant improvements in psychological outcomes in many different studies. But because some of the nuances that can come with surgery, such as obvious physical risks, I mainly argue for speeding up the transition of the first 3 steps here. I wanted to quickly acknowledge some of the other side of the argument, which is often pointing to regret or safety issues. Many studies actually show that once puberty is hit, it is very unlikely that one is going to change their gender identity, and this is when partially or completely irreversible treatment should be begun. In terms of safety, puberty suppressants can cause some minor changes, such as decreases in bone density, but these typically resolve themselves very quickly with the onset of cross-sex hormones. Cross-sex hormones can impair fertility potentially, but there are many options that can be given to individuals going through this, such as the freezing of eggs and sperm so they can be later accessed later in life if one so desires. I think most important here, though, is that the risks that come with passing through the wrong puberty are far more severe than anything that can come from these treatments. But we also have to keep in mind that there's a lot of limitations in the studies that we have right now, and we don't know a lot about the effects of puberty suppressants on those below the age of 12 and on cross-sex hormones on those below the age of 16. I kind of wanted to look quickly at some of the current events that are happening in our country that I believe to be very unethical. In 2023 already, we've seen a lot of bans that are barring minors as well as adults from accessing gender-affirming care. Even those up to the age of 21 in certain states aren't able to get the care that they need, which is 3 years after they should have full bodily autonomy. Also, a lot of health plans are no longer required to provide coverage for gender-affirming care, which leaves a lot unable to afford this care that they need. Third, physicians who provide gender-affirming care to minors can be charged as malpractice or as well even be criminalized in many different states. And then finally, I wanted to address the most recent bill that happened in Florida, which even allows courts to take children away from their parents if they're receiving gender-affirming care, which is far more harmful than anything that the care could provide. Perhaps the most unsettling part about all of this is that these bills are based on scientifically inaccurate information. Going in more specifically into the ethics, the most obvious one here is non-maleficence, as physicians must evaluate all of the risks and look at each specific situation to make sure that they're not causing any harm to their patients. The next is beneficence, where physicians must look at how they can benefit the mental health and well-being of the child that they're treating. Right now, I believe that is by providing the most safe and comprehensible care that we have here in the United States, such as puberty suppressants and cross-sex hormones. The next is the principle of justice. And I believe that every child has the right to go through the correct puberty just as the rest of their peers do. And I believe they also have the right to be affirmed and accepted in their gender identity. And finally, the most nuanced, the principle of autonomy. This is a bit hard here because children obviously are not of legal age to have medical autonomy over their own bodies, but I do think they should have a serious input before the age of 18, especially when it comes to gender-affirming care. Currently, one cannot receive surgery until 18 years old, and you can't get cross-sex hormones until 16 years old. I argue that by delaying this treatment even to the age of 16, we are causing detrimental health outcomes for youth because we are keeping them in a pre-pubertal state that doesn't allow them to develop alongside their peers and essentially can lead to serious isolation. I also argue that requiring parental consent can be detrimental because it not only may delay a lot of transitions from happening as soon as they could, but it also is really detrimental to those who do not have this social support system. Currently, there are no exceptions in the US for this law, but in the UK, courts are able to overrule the law of parental consent if it's deemed in the best interest of the child. I think here we need to make a case-by-case basis for each child to make sure that we're making the best possible decision based on everyone's specific needs. And this should be based not only on age, but on their deemed maturity. So what do I think should be common practice in the United States? First, we need to be prioritizing research on the youngest possible age that we can be beginning each of these treatment steps so that we are not delaying anything further than it needs to be. Finally, I think we need to allow children to begin transitioning when they feel ready, but also when they are obviously deemed mentally ready by a professional. And I think by taking these actions, we can drastically improve the mental health outcomes of transgender youth in the United States. And this should be a utmost priority. Thank you.
Good afternoon, everyone. I'm Shelby, and I'm currently a junior neuroscience major and philosophy minor. And today I'm going to be talking about the ethics of parental consent when it comes to minors obtaining abortions. So first, to dive into this issue, I find it most interesting to first bring up the case. So we have a 16-year-old who is currently 10 weeks pregnant. She is in school with no job, and therefore she is unable to provide for a child at this time. And she currently lives in a state with more restrictive abortion laws. Specifically, the legal abortion in this state only allows up to 15 weeks. She has also decided that she doesn't want to involve her parents in this decision because she feels like her parents most likely won't agree with this decision. So therefore, she has decided to file for judicial bypass in order to bypass the parental consent and notification laws. However, and she has also told the court that she is not ready to have a baby yet. However, she has also just suffered the death of a friend, and therefore, because of this, the court has decided not to grant her judicial bypass at this moment and to reevaluate her case at a later date because of this stressor. However, what this case really highlights and what I want to point out about judicial bypass is that oftentimes it's going to delay care. And in cases like this, it's really important that that people are able to have access to care in a timely fashion because she is someone who is currently at a later stage in her pregnancy. And oftentimes, minors can surpass that legal window of 15 weeks, depending on which state they're in, which means that they wouldn't be able to get the care that they need. Another issue that it really highlights is that oftentimes judicial bypass can be a really arbitrary process depending on which state that minors live in, especially in more restrictive states, and I'll talk about that a little bit later. The unfortunate thing about this case is that it is not hypothetical. It is one that actually occurred in Florida in 2022, and this is just the reality for a lot of minors who try to obtain judicial bypass, especially in restrictive states. So, first of all, what is judicial bypass? Essentially, it is a process and it is an order from a judge that allows minors to get an abortion without parental consent in states that require it. Today, currently, 36 states do require parental consent and notification involvement to some degree. This process is confidential and anonymous when the minor is going to file for this application. But the issue with this is that minors must be first aware of this right in order to exercise it. It is almost unreasonable to require that minors understand how to navigate the court system, and it places an undue burden on them as a result. And so studies have shown that in states with more restrictive abortion laws, there is a 34% higher maternal mortality rate in restrictive states, which is very concerning. So who exactly is getting judicial bypass? Well, 4 in 10 minors don't involve their parents in these type of decisions because of unstable family dynamics, where they have either experienced some family violence in the past, and they fear that either their parents won't agree with them or that this is just going to exacerbate certain unsafe conditions within their family. And so something interesting about judicial bypass is also that the criteria for granting it is evaluating a minor's maturity and competency for decision-making. However, the legal language says that minors must be mature enough and well enough informed. And so this language is pretty vague and leaves a lot up to interpretation for judges. And as a result, the outcomes really do vary depending on how lenient or how restrictive the state is going to be. Some cases, evaluating maturity even comes down to looking at a person's GPA, which is just simply arbitrary. And so, although the legal age of determining whether someone is competent enough to give informed consent is age 18, this in no way is a magic number. Cognitive research has actually shown that minors around ages 14 to 17 are just as capable of making rational decisions, as well as understanding the risks and benefits as adults. And so, although parental consent and notification laws do exist in order to protect a minor's to protect that informed consent is being given and not violated, parents are usually involved. However, the younger the minor is, the more likely they are to consult a parent anyways or a trusted adult, and a majority of minors do end up consulting a trusted adult anyways, even if it's not their parents. But something to consider here is that if parental consent and notification laws were really put into place in order to safeguard against violations of informed consent, then why is it that parents aren't involved when the minor decides to go ahead and proceed with their pregnancy, as they are treated as adults in those cases? So I argue that judicial bypass can be extremely invasive and thus and also violate a minor's right to privacy. This is because when they're in court, they are required to disclose very personal information about their private life and their sexual history in front of other people, whether it be witnesses, the judge, or other people working in the court. And as a result, this can cause some psychological trauma. It's really important to protect privacy, especially as a perceived lack of privacy can deter minors from seeking care altogether regarding sexual health. And so I also argue that judicial bypass in general places unnecessary barriers on minors, especially in unique circumstances. On average, minors have to travel an average of 24.4 miles just one way in order to get to the court that allows them to have the court hearing. And in addition, they have to wait an average of 1 week for the court hearing, and then additional 6.3 days on average for the abortion appointment. So this really delays the access to care as well as timely care, because on average it extends that waiting time to 2 weeks, which for some people can allow them to go beyond that legal limit and therefore not able to obtain a legal abortion. So what are some solutions to this problem? Well, it is very challenging as well as nuanced, but I just offer some simple solutions here, although they are not foolproof. So the first I argue is addressing this at a systemic level, acknowledging systemic barriers such as financial burdens, access to confidential care, as well as lack of transportation. Furthermore, navigating the judicial process is very difficult. So I argue for having better resources, whether it be through healthcare providers or through schools. And then lastly, we possibly could expand the legal language into trusted adults or other family member rather than guardian or parent. And this might mitigate some of the issues that judicial bypass brings up. However, in no way is this an exhaustive list of potential solutions, and we must do better in order to protect the bodily autonomy of minors. Thank you.
All right, I'm Chris. I'm a senior bio major, biotech minor, and I will be talking about the ethical complexities of human embryonic stem cells. All right, what do you think is the current estimated number of cryopreserved human embryos in the United States? Otherwise saying, the amount of frozen embryos within the United States. Just shout out a number, any number.
200,000.
All right, 200,000.
10.
What was that?
10 million.
10 million. Oh, okay. Well, currently estimated there's over 1 million embryos that are either in research facilities or in fertility clinics. And that's mainly due to in vitro fertilization. That's one of the main procedures that causes this abundance and surplus of embryos, because individuals that are going through that procedure will only use one of the embryos, and 9 to 15 embryos are essentially produced from that procedure, as Oriel was saying in his presentation. And so with understanding these numbers, we want to understand why these numbers are important. And to understand that, we need to understand why human embryonic stem cells are important. So, source and origins. So, essentially, human embryonic stem cells come from the blastocyst, which is the structure that is formed 5 to 6 days after fertilization has happened. And so, we want to pay attention to the internal cell mass here. That's where your human embryonic stem cells are going to be. And so that's going to be extracted and then isolated, and then the embryonic stem cells can be used. And so with knowing that, then you want to go into the characteristics of why it's important that we have these. And so the pluripotency of them shows the main reason why they're so important and vital is that they can differentiate into any cell lineage of ectoderm, mesoderm, or endoderm, which is completely different from multipotent and unipotent cells, which are way more specialized, or way more specific to what cell type they are. And then next is your undifferentiation characteristic of where gene expression for these hasn't been silenced or upregulated. So it essentially allows researchers, it gives researchers a blank canvas to go in a different direction of what research they want to do when working with the embryonic stem cells. And then lastly is self-renewing, meaning that once you have an isolated internal cell mass of embryonic stem cells, they can just indefinitely replicate. So that's just, for the researcher, it's so much easier, and it's just going to be a vital source for embryonic stem cells within their lab. But with knowing these potentials and characteristics of embryonic stem cells, there's still ethical complexities of them and questions that are hindering and causing the advancement of them. And so specifically, I talked about 3 within my blog project. There's obviously way more, but the first one is the status view of human embryonic stem cells. And that's basically the ontological status of them, where most individuals, it's questioning the aspect of whether human embryonic stem cells should be have the same equivalent moral status as that to an embryo or a human. And individuals that argue that yes, they should have the same moral status, they argue it in the sense that because they have the potential to become an embryo and develop into a human, they should be considered the same moral status. But that potential is only when you have the correct external factors given to those isolated embryonic stem cells. And so I argue in the sense that because you have to add those external factors to the human embryonic stem cells, that they can't independently divide and fully be formed into an embryo, fully be formed into a human being. So then they shouldn't be considered to have the same moral status as them. My next argument is a means to an end of human embryonic stem cells. And this is looking at individuals arguing that it's not morally justifiable to destroy a human embryo through the extraction of the ICM, just even if it is for the use of curing a disease or further developing human health. And so individuals view it as, these are mostly individuals who view a human embryo as having the same moral status as a human being. And so they question the fact of how does the end of healing, the end goal of healing, how is that morally justified with using something that has the same moral status as a human being? But I kind of question it in the sense of like, what's more ethical, having those embryos stay preserved in the research facility for who knows how long, or they're just going to be discarded? Is it more ethical to do that, or at least give them some sort of meaning, some sort of purpose with, in the sense of advancing human health? And so I say it's a merely means to an end because we're still respecting the moral status of the embryos, but give them some sort of meaning and some sort of purpose with reaching the common end goal of healing and preventing suffering within individuals. And that end goal is justified because we're essentially providing a cure for an individual who might otherwise have an uncurable disease. And that helps us, that essentially allows us to uphold human dignity with having the end goal of healing. And my last point is the principle of beneficence and human embryonic stem cells. So beneficence can be known as persons, where persons are treated in an ethical manner, not only by respecting their decisions and protecting them from harm, but also making efforts to secure their well-being. And so individuals that argue, who are against human embryonic stem cell research, they argue that this principle of beneficence is violated within the research because the autonomy and the well-being of human embryos isn't respected. And so I say, what about the beneficence of the patient? What about the beneficence of an individual where their only chance is a human embryonic stem cell treatment? And so that comes down to the question of human embryonic stem cells will further in the future will provide many advancements in medicine. Specifically, there's already research within spinal cord injuries, within heart repairs, diabetes, retina degeneration. And so it comes into question of, well, if that's the only individual's option, and you take away that, isn't that removing, kind of violating that beneficence, because we're not trying our most to secure their well-being. And so these were just some of the arguments I came up with while reading the literature. There's obviously tons more arguments that can be made, but until we can figure out how to navigate through these arguments, embryonic stem cell research will still be halted for a little bit, but I think in the future it's an upward trajectory. And yeah, that's it.
Afternoon, everyone. My name is Francis. I'm a junior studying public health. And before I begin, I just wanted to give you a clarification on what direct-to-consumer genetic testing is. So in my blog post, I looked at the best way to promote the principle of justice in direct-to-consumer genetic testing. And so I'm not going to make you guys raise your hands, but a lot of people have done this. And it's like you spin a vial, you ship it off in the mail, and then a few weeks later, they'll tell you about maybe your ancestry or some health traits. And there are popular companies like 23andMe and Ancestry.com. And to give you a scope about the market, since 2022, the direct-to-consumer genetic testing market has surpassed over $3 billion, and it's estimated that in the United States alone, over 100 million individuals have completed such a test. And 23andMe, which is a really big industry company, they reported about $270 million in revenue in the fiscal year of 2022. So the reason why it's so popular is because it's really accessible. You can get it at your local supermarket, like Walmart or Target, or you can also buy it online at Amazon. And another reason why it's so popular is because it doesn't require a physician's approval or any provider's approval to get the test authorized, compared to a clinical test, like in a hospital or a clinic. You'll have to chat with your provider, be like, hey, can I get this test? And a reason why this raises concern for me is because historically in the patient-provider relationship, the patient talks with the provider about the risks and concerns about a genetic test, what it can mean. And in direct-to-consumer genetic testing, there is no need for any prior medical professional authorization before, during, or after. And so imagine you spit in a vial, submit a test, and a few weeks later, the 23andMe website says you have a BRCA mutation, saying that you're at risk for breast cancer. I don't know about you guys, but I would be afraid, anxious, and I'd be horrified. And unfortunately, no company currently provides direct access to a qualified health professional to discuss these results. Rather, the 23andMe portal gives like generalized information about what this means, but nothing specific to the individual, and it's mostly just information about the limitations of the test. So going on to the psychological impacts of this, currently no direct-to-consumer genetic testing company like 23andMe or Ancestry.com has any legal obligation to provide direct access to a qualified professional. And it can be said, and it's true, that most consumers that do take these tests are generally healthy and maybe they're trying to learn about their ancestry, but they don't have any positive test results. However, it's clear in multiple studies that having a positive direct-to-consumer genetic testing result, such as like the example of BRCA, it's clear that it's associated with a higher level of anxiety and stress overall. And reading blog posts from genetic counselors, it's clear that genetic counselors who have dealt with clients seeking genetic counseling, that these consumers should and would benefit from direct access to a qualified professional before and after the testing. So talking about the ethical principle of beneficence, it's clear that these direct-to-consumer genetic testing companies aren't working towards the beneficence of the consumer. They could be promoting the consumer's well-being through providing access to direct consumer testing, but they don't. Instead, they have these disclaimers saying, don't use this as health information, don't act on this. However, unfortunately, I argue that these are just legal obligations they have to fulfill to be in compliance with the FDA, because they don't actually offer the services it recommends, such as the medical help. Going on to the principle of justice, which I argue is the main principle at stake, it's clear that the vulnerable consumers are the most afflicted. Those individuals who test positive, while they are a minority, they are the ones bearing the burden in the situation. Furthermore, historically marginalized communities seek access or seek healthcare in general at lower rates than other communities. Studies show that people of color are less likely to access follow-up care after direct-to-consumer genetic testing than non-people of color. Additionally, there are significant economic barriers towards accessing genetic counseling. A single genetic counseling session can cost up to $100, and that can definitely be a barrier to some people. So the question remains, how can we ensure that all consumers have access to a qualified professional? In the current state of direct-to-consumer genetic testing, it's not guaranteed that once I take this test, I'll have a provider to talk to discuss these results, especially if they're positive. And I argue that there needs to be some sort of legal or business incentive for these companies, because otherwise they have no reason to do so unless they want to cut in their profit. And in the future, we must consider that there are significant disparities in the realm of direct-consumer genetic testing. Even though these tests will benefit many, they'll provide actionable health information for people to make lifestyle changes. It's clear that the few who do test positive will bear a significant burden of psychological stress. So I argue that direct-to-consumer genetic testing companies must provide equal access to ensure equal health for all. That's it. Thank you.
Hi everyone, my name is Olivia Pruitt. I'm a senior, almost can say I studied past tense, public health and political science here. And I'm going to be talking to you today about the implications of trigger bans on reproductive healthcare practice, and in two related segments. The first is what does this mean for physicians' ethical obligations, and then the second is if doctors do end up leaving states with strict abortion bans, what does that mean for the reproductive healthcare system and then our healthcare system as a whole? So first, this is something I'm not going to beat the horse here, especially because a lot of people are talking about abortion and in different segments, but something obviously that we need to talk about for today for my presentation is the Dobbs decision. So this is just from Google Trends, and it shows searches on Google, anything related to the word abortion. And you'll see June 19th to 25th, 2022, there was an 8 times increase of searches with the word abortion in it. And one of the interesting things that I've actually found due to some research that I did right after the Dobbs decision came out is that a lot of those Google searches were actually physicians wondering what was going to happen to their practice and what they should do if someone came in, they needed an abortion, were they allowed to give it? So The big issue here is, the ethical issue is, now that we know that doctors are leaving states with strict abortion bans, what does that mean? So an article that came out actually just a couple of weeks ago from Idaho showed that 5 out of 9 remaining maternal fetal medicine physicians in the state were going to have left by the end of 2023. So that's that's an optimistic 4 maternal fetal medicine doctors that will be left in the entire state of Idaho by the end of 2023. So the first is what does this mean for ethical principles, for doctors reaching for their patients, and then again, the healthcare system as a whole. So first, these principles, we talked a lot about this quarter, and the 3 that I'm going to talk to you about today are beneficence, non-maleficence, and justice, and then kind of facets of a couple of those. So the first is beneficence. That is just this idea that you should do the most good for your patients. But physicians are wondering, do I do the most good for my patients elsewhere? So not in this state. Are they really leaving states that have strict abortion bans? The second is non-maleficence, so that's the do no harm principle. So are they doing harm by not actually being able to provide the necessary care for their patients? And that's even sometimes just recommending that a patient, for an ectopic pregnancy, a pregnancy that might actually be in a fallopian tube, which is very high rates of both maternal mortality and also the fetus does not survive. And in some states, you're not allowed to act until that mother is in imminent danger. So what does that mean? If you're not doing that harm, do you have to send them to another state? If you tell them they can go to another state, do you get in trouble? And that's happened in a couple states. And I think this is kind of like telling, a surgeon to go into the OR and they're like, do the surgery, but without your hands. It's kind of like, can you really, really give your patients the care that you need if you can't actually tell them what the risks are? Next is justice. I think this comes pretty obvious. So do you choose to practice and advocate in states with more resources, like better labor and delivery units, or do you continue to provide any care in any capacity without leaving people behind? And those, I know Shelby talked a little bit about increased maternal mortality rates, and especially in this case, people of color. And then if you do stay and you practice, do you lose your license? And then obviously between the doctor-patient relationship, between the provider and the patient, you have to give advice based on the values and the best medical practice available. But if you're not allowed to give the best medical practice available, are you leaving? In a lot of cases, it looks like yes. And then finally, informed consent. So that's from the provider to the patient, being able to actually explain what's happening to you, being able to actually explain what's going on in a pregnant person's body. In a lot of cases, there's a lot of concern for being able to even just explain to the patient, that they might not survive, or that their baby might not survive, and then tell them what their options are. And so that window is getting much more narrow. And then also, you have to take care of the patient first before you can refer or consult another doctor. And you can also get in trouble for referring patients in stricter abortion states, even if you're not actually practicing the abortion in that state. The second ethical issue is, what does this mean for the healthcare system? And if doctors are leaving, so they're leaving the state, they are changing practice to go from either obstetrics and gynecology, and they're kind of bumping down to like more general practice, or they're retiring early. So the first is clinics are closing, especially in states with more strict abortion bans. So 25 to 26 of the 50 states have some form of abortion ban after the Dobbs decision overturned Roe v. Wade. The first is a pretty famous case that we have talked about a lot. I'm sure you've heard about it. Idaho, Bonner General Health was a hospital in Standpoint, Idaho. It was the only hospital in the area for many, many, many miles, and they chose to close their labor delivery unit because of the law, and also because they just couldn't find any physicians to work in that unit. The second is the Chartist report. So that shows that policy and physician shortages are causing this loss of access to obstetrics in many states, but especially Minnesota, Texas, Iowa, and Kansas all had 10 plus clinic closures in the last 5 years when the conversation around abortion has increased. Second is what they're calling reproductive brain drain. So this is that doctors don't want to practice in states anymore. 76% of doctors in a 2,000 doctor study won't apply to work in strict abortion states. That's a lot of doctors, especially when we know that Idaho only had 9 people by the end of this year. And then also recent grads, maybe some of my classmates, are choosing to not apply for residencies in states with complete bans by almost half. So obstetrics and gynecology residencies are actually going down by, I think, in the last couple of years by 45%, but especially in states with strict abortion bans, that's almost 10 to 15% reduction in residencies. And finally, we're losing 50 years of progress. The Turnaway study out of the Answer Clinic in Texas shows worse health outcomes for mothers and babies, lower socioeconomic status, especially for the first 4 years of life, and higher rates of interpersonal violence for mothers of unwanted pregnancies because they have to go back to homes where they can't support themselves because abortion services are not just abortion. That includes everything. And then finally, I'm calling this perfect storm, and there's no clinics and then there are no resources. So what does this mean? What does this mean for the future? Basically, we need to look at, so not just policy solutions, but we need to sort of tell policymakers that this issue is not just, providing abortions, it's also affecting the whole reproductive healthcare system, and therefore our whole healthcare system. Clinics are closing, doctors are leaving the field, and people aren't getting the care that they need. So this is the sort of sound the alarm, and I'll leave you with, we shouldn't leave sort of what does a world look like without reproductive healthcare to people like George Orwell, Lois Lowry, Ray Bradbury, in sort of like a post-apocalyptic world. Thank you.
Hi everyone, good evening. Thank you for giving us your time tonight. My name is Tisha Hartman. I'm a neuroscience major and a biology minor here at SCU. And tonight I'd like to talk about the intersection of poverty, addiction, and health outcomes. In the United States, right now today, we have 40 million people living in poverty. We're talking poverty where households as a combined income are earning less than $22,000 a year with children. That's 12% of our population. Half of that is estimated to have a substance use disorder. Right now, in the last year, we've lost 107,000 people. That's 294 people per day. The stakes are very high here. Overdose has become the leading cause of death, injury-related death, and 70% of that is opioid-related. Now, of that 21 million people in the United States battling substance abuse, what I found most shocking was that only 3.8 million are receiving treatment. You might be asking, why would only 3.8 million people be receiving treatment when clearly it's a pervasive problem? I mean, we've had presidents who've declared this a national crisis, and the numbers are supporting that. Well, that was a question that I sought to get the answer to. And as you can imagine, it's a multifaceted problem. There are many things that contribute to the rates of addiction and treatment barriers. But tonight I'd like to discuss provider biases. Oops, sorry. So I undertook looking at many different studies. There was about 20 studies in total, and one thing that they all overwhelmingly had in common was that provider biases is a significant barrier to treatment. Some of these studies found that physician willingness to treat, I say that one more time, the physician's willingness to treat an addict was significantly lower if the physician believed they themselves were impervious to addiction, or if the physician thought it was a moral weakness. The study also found that many of these physicians who were surveyed, who are extremely educated, who've spent years pursuing the medicine of science and understanding the underpinnings of biochemical processes in the human body, were completely misinformed about what addiction is, right? So these researchers set out to go, okay, clearly we have a problem. We have bias in medicine around addiction. So what is that translating to from the patient population? And what they found, and they surveyed many, many people, one survey alone did over 2,000 people with a diagnosed substance use disorder. So we're talking a pretty big data set here. And again, this was across 20 different studies. That was just one study. What they found that was over 78% of people with a diagnosed substance use disorder had reported at least, and I emphasize at least, one instance of bias in trying to seek treatment. So what is that culminating to? Basically, people with substance abuse are avoiding treatment because they don't want to deal with the stigma. That's a problem. As you can imagine, with any health problem, if you're not seeking treatment, your health outcomes aren't going to be good. And the data supports that if you do seek treatment, addiction can be dealt with, right? One of the problems with addiction, much like any other chronic disease, is that if you stop treatment, the addiction comes back, right? And so this becomes a battle that you have to manage lifelong, just like you have to take pills for cholesterol for the rest of your life and all of the other kinds of chronic illness that we carry. So what I found most interesting in this research is that there were two departments in particular in medicine that had the highest amounts of explicit bias: emergency medicine and obstetrics and gynecology. So that's labor and delivery, right? So what they found is that a majority of these physicians didn't even believe these people deserved access to quality care, that they didn't even deserve access to care. Like, I can't even fathom that personally. What they also found is that the majority, and that is a direct quote, the majority of labor and delivery nurses felt that pregnant women with a substance use disorder should be in prison. And that the more that a nurse had worked with this particular patient population, the more they had these negative biases, which contradicts some of the other research out there. If you've looked at how to overcome biases in medicine, they'll talk a lot about exposing the provider to that patient population and that helping to overcome biases. But the research I found showed very much the opposite, that the more the providers were engaged with this population, the more biases they had. So what's shifting? Well, in the early 2000s, most overdoses were from prescription medicines. That caused a bit of a panic in the medical community, and they've shifted, many physicians have shifted prescriptions now out to pain management centers. Today, we have a much higher rate of overdose, as we've already talked about, 100,000 plus per year, 294 people per day, right? So the numbers are increasing year over year. They're not getting it from their doctors. Those numbers are down. They're getting it from the street. What's shocking is who's getting it, right? A 2016 Kaiser study found that the majority of their opioid prescription users were pregnant women. And a 2017 SAMHSA study, and if you aren't familiar with SAMHSA, they're like a governing agency, nonprofit, that kind of governs the substance use professionals industry. They found that the majority of new heroin users were women, actually white women to be precise. So what we're talking about here is a problem that is growing every year, and its span, and I believe I have a slide here with me. Yes, this slide here. We're showing here the opioid death rates across the United States. The red is the upper outlier area. The blue, the dark blue, is the lower outlier area. I challenge you to find somewhere on that map with dark blue. That's how pervasive this problem is. I can tell you that it's touched probably 1 in 5 people in this room, either through a friend, a family member, or a loved one. So this is a very real problem for the United States. And if we're not getting care, if we're not getting treatment, and the problem is growing. But it isn't just the addicts whose lives are at stake. We're talking about children. I spent the last year working in a county rehab here that was unique in that it served the women and children. So these women came to us and their babies and them were both withdrawing from drugs. I've seen very real consequences of this. When we as providers are treating patients with substance use, we're not just treating the patient, we are treating the whole family, right? And so I believe that it's a moral obligation of society to address biases in medicine around addiction. Thank you.
Hi everyone, my name is Sydney Pattison. I'm a senior neuroscience major and biology minor. Thank you all for being here. Before I begin, I'd like to pose a few questions that I'd like you to consider in a few minutes. First, how should the U.S. address the homeless crisis? Second, How should the U.S. address the mental health crisis? And finally, what are we supposed to do when these two things intersect? Mental health care for the homeless is a moral obligation. The United States is failing. I'd like to introduce two individuals who have attempted to answer these questions. The first is Eric Adams, Mayor of New York City, and the second is Ted Wheeler, Mayor of Portland, Oregon. In New York, Adams proposed an initiative that would allow the New York Police Department to take into custody homeless individuals who appear to be mentally ill or a danger to themselves because of their mental illness. In Oregon, Wheeler has expressed a desire to lower the standard of care, or the standard required to commit individuals to care because of their mental illness. In New York, it's currently required that homeless individuals are a threat to others in order to be involuntarily committed. And in Portland, it's required that these individuals appear to be a threat to themselves. While these new propositions might sound noble in theory, they have two major failures. First, the United States lacks the necessary amount of mental health professionals and infrastructure to support our current need. According to KFF, a nonpartisan organization focused on health policy, only 30% of the U.S. national mental health provider need was met as of September 2022. Some research has suggested a shortage of 15 to 30,000 psychiatrists by the year 2024. Other mental health providers, nurses, social workers are likely to experience shortages in the coming years as well. What this means is that by lowering the standard required to admit these individuals to care, we're adding more pressure to an already strained system. In addition, the U.S. lacks the physical space to care for these individuals. This is partly due to the process of deinstitutionalization, which is the closing of psychiatric hospitals in favor of family or community-based care. Together, what this tells us, we just can't support these people at this very moment. We don't have enough in the system already to meet our need. Pitfall number 2. These plans rely heavily on the local police to find homeless individuals in need of mental health care. In 2010, the New York Police Department's Homeless Outreach Unit, a team that's designed to transition homeless individuals to shelters and into other support programs, actually arrested 2,000 people for petty crimes. Sounds to me like the police aren't the right people for this kind of job. In addition, the U.S. homeless population overrepresents minorities. Together, these two realities pose a significant threat to justice. It is extremely likely that these sorts of policies, especially the ones that involve the police, will only further the differential treatment of racial and ethnic minorities, lower socioeconomic classes, especially in the context of healthcare. So, I'd like to introduce Gavin Newsom, Governor of California, who has a different way of addressing these sorts of issues. Newsom recently enacted the California Community Assistance, Recovery, and Empowerment Act, or CARE Act, which allows judges to write treatment plans for individuals diagnosed with schizophrenia or other psychotic disorders. This plan especially targets the most vulnerable, those who are at risk of incarceration or homelessness, including those who are already homeless, because of their mental illness. The CARE plan has 5 steps, the first of which is referral. An individual is committed or referred to care by someone that they know, a friend, a family member, a healthcare provider, a first responder. And the goal of this step is to ensure that these individuals get the care that they need before they're institutionalized. The second step is clinical evaluation. A care court judge determines if the person meets the criteria. At this point, they're also appointed legal counsel, a support person if they so choose. The next step is the care plan development. The whole team works together. This includes the legal counsel, the individual, their support person, and county behavioral health centers to write a treatment plan that composes of behavioral treatment, medication, and also housing. This plan is in place for 1 year. Step 4 is support. Throughout that first year of treatment, there are regular meetings to talk about how things are going. What's working? What needs to change? Does this plan need to be extended for another year? Final step, success. Once the individual completes their program, they are still eligible for support, housing, treatment, basically everything that they were provided through the CARE Act. So why is this better? First, because this plan uses county behavioral health centers rather than state institutions, state providers, we're transferring the strain on the system away from those sorts of institutions, those sorts of hospitals. Additionally, because we're not as reliant on the police, and these individuals are appointed legal counsel, additional supporters, there's a better chance that these individuals will have their voices heard. They'll maintain their autonomy, they'll be treated justly and respectfully, and hopefully they'll get the care that they deserve. However, there are still failures. Like I mentioned, the biggest of which has to do with strain on the system. Even though we're no longer relying on the state hospitals, the state providers, we're transferring that strain to the county behavioral health centers. Again, we're likely to face the same issue here. We don't have enough providers. So, what are we supposed to do? Frankly, I don't have a perfect answer for you all, but I want to make one thing abundantly clear. It is not the case that these individuals do not deserve care. They absolutely do. However, I believe it is an ethical failure to commit these individuals to care in a system that can't support them. If policymakers truly want to fulfill their moral obligation to these individuals, they must create healthcare systems and mental health care facilities that are conducive to holistic, equitable care for all. It is of the utmost importance that these individuals, given that they are the most vulnerable, have the opportunity to maintain their autonomy, be treated with respect and justice, and get the care that they really deserve. Thank you.
Hello everyone, my name is Chloe. I'm a senior at Santa Clara. I'm studying biology and public health on the pre-medical track. Today I'm going to talk to you about what emergency departments look like following the overturning of Roe v. Wade. I know that we've talked about this a lot, so I'm just going to do a quick summary, but following the Dobbs v. Jackson Women's Health decision in June of 2022, about a year ago, the constitutional right to abortion was eliminated following the overturn of Roe v. Wade. So in order to explain the magnitude of this decision, I want to take you through a hypothetical scenario. So imagine that you're an emergency medicine physician in an emergency department, one of the only few in the area. You're short-staffed following the pandemic. You don't have a lot of resources. A lot of your staff is tired. And in comes a 24-year-old patient flying through your emergency department doors. It's clear that the patient is in distress. Upon transfer, the EMTs tell you that she was brought in after fainting at work. Her coworkers told the EMTs that the reason that she fainted was most likely due to abdominal pain, as she was complaining about it for weeks prior. You do your assessment and you realize that this patient is indeed having an ectopic pregnancy. You know that the recommended course of treatment for an ectopic pregnancy is an abortion. However, you are a physician in a trigger state. The trigger state means that the second that Roe v. Wade was overturned, abortion is now illegal in your state. You know that you can only provide abortion in an emergency manner when the patient is unstable. Your patient, while in complete obvious distress and suffering, is technically stable. Her heart rate is okay, her breathing rate is normal, her BP is a little elevated but within somewhat normal range. So instead, you have to wait. Do you wait 5 minutes? Do you wait 90 seconds? Do you wait 20 seconds to help this patient? Do you take the risk and wait and potentially harm this patient, or do you potentially just act now and put your medical license at risk, potentially facing jail time or large fines? What would you do? I don't know. It's extremely complex and confusing. And that is the underlying situation that emergency departments are facing today. So the matter of the story is that even though Roe v. Wade was overturned, abortions are still going to continue. You can see that people following Roe v. Wade have continued to travel out of state for abortions.
even when Roe v. Wade was not overturned, people still were traveling out of state. So you can imagine that this is just going to be emphasized following the overturn. Additionally, women are still going to have abortions. While it might not be legal, they will perform abortions by themselves. This leaves a ton of space for a ton of complications and unsafe measures. We're essentially putting these patients at more extreme risk, requiring them to travel far distances while also putting them in a position that essentially could hurt their physical health. We are stacking the odds against patients. I know this presentation is mainly taking a physician's perspective, but I also want to realize from the patient perspective. You can see here, even to make the matters more confusing, some states ban abortion completely, some states they have underlying rules, and some states are these safe haven states, which also, again, make the situation even more confusing. You can see that the policy is super unclear. And you can imagine that being a physician while trying to treat your patient, but also remembering what legislation is happening in your state in the heat of the moment with a ton of stuff happening around you, that is an impossible, very difficult situation to be in. And we are putting this expectation on our physicians, which is extremely harmful. So not only do we have extreme risk on the patients, but also on the physicians. So where do we go from here? Obviously, overturning Roe v. Wade is not the end-all, be-all solution like the legislators think. Healthcare needs to be on a patient-by-patient basis. When a patient comes in needing an abortion, it is important that we tailor the care to that specific need. Also, we need to find a way to remove this legislative confusion. As you can tell from these hypothetical scenarios and all the other data, it is very hard to be able to navigate a world like this. Physicians are left trying to come up with medical decisions, but also trying to navigate the extremely complex world of legislation in the heat of a moment in a split second. Lastly, let's leave healthcare decisions to the professionals. They have gone through extensive training, a ton of school, and will ultimately make the right decision for the patient. People that are in the government that are making these laws are not familiar with everything that ties into a medical decision. Thank you.
Good evening, everyone. My name is Joseph Wasco. I'm a senior, I'm a biology major, and a public health minor. And so far tonight, we've heard several wonderful presentations from a number of my peers talking about issues like stem cells, abortion, and now ethics. But now I want to turn your attention to an issue I believe that doesn't get enough attention and should stand beside all these other issues that garner a lot of attention in the media, as well as our classroom. And that is global medical volunteering. I've had the good fortune of being able to participate in global medical volunteering experience last summer. And so tonight I want to start by talking a little bit about my experience as briefly as I can, so I can talk about that till the day ends. And then I want to move into some of the issues that plague the industry, as well as some solutions that I proposed in my article. And so last summer, as I mentioned, I had the good fortune of being able to travel to Guatemala. I don't have a slide on this, so I'm just going to stay here. But and it was something that I participated in not because I wanted to, polish up my medical school resume, because at the time I didn't even consider going into medicine. It was still something that was in the back of my mind, but I wasn't really committed to it. But I knew from the very beginning of college I wanted to have the opportunity to travel. I didn't really get that because of COVID. But when I heard of this opportunity to go abroad and volunteer at a clinic in Guatemala, I thought I could have a meaningful impact on an underserved community, which is something that I had the good fortune of being able to participate in, again, when I was 13 years old. And so I thought I could have the same level of fulfillment from this, as well as be able to apply the public health work that I had just begun doing and found a new appreciation for it. And so last summer I found myself in Guatemala for 15 days, and to my surprise when we arrived there, it wasn't anything like I thought it was going to be like. Rather than being in one clinic, I found myself sitting on a bus driving 2 hours every day to a bunch of different communities that were far away from where we were staying. And the communities that we were in were nothing like what I thought I was going to see. Before the trip, I thought I was going to have to develop my Spanish speaking abilities and be able to speak proficiently so I can provide competent care. To my surprise, none of my patients, or none of my peers' patients, spoke Spanish. And this is a challenge that the healthcare industry abroad faces, generally speaking, especially in Guatemala, where the physicians speak Spanish, but the patients don't. Anyways, upon returning from the trip, I remember talking to some of my friends and some of my family about the experience, and I recall feeling like I came back with some skills on how to do certain procedures in medicine, which is largely just how do we take blood pressure and measure blood oxygenation levels. But what stuck with me more was kind of the cultural and public health impact that I had. And I had a lot of questions about whether or not what I did there was at first right, or what happened to my patients after I left. I was only there for 15 days, so after I saw them, what happened to them? Did they have access to care after I left? Or did they just go back to living their lives the way it was before, with limited access to care in a country where only 5% of the population has access to health insurance? And so when I found out I got to delve into an ethical issue in this project, I was eager to jump on global medical volunteering, read the literature, and explore more of what matters to me. And in doing so, I first came across an article that was published in the AMA Journal of Ethics that encompassed, that described the issue, I think, very appropriately. And I call it IMV imperialism. That's a flashy word. I think the word they use in the article is neo-colonialist perspective, which is very jargony, and while my historian parents might appreciate me using history words, for you, what that the easiest way to understand it is just the white savior complex. The most obvious issue with a lot of global medical volunteering programs is that you have people who look like me, or people from just the United States or developed countries in general, who go into these countries, assert their influence, and pretend like what they're doing in their country is wrong, and that the way they practice medicine is wrong, and the way that we do it is right. And this inadvertently neglects patient autonomy, and it also does harm for patients, because believe it or not, the way healthcare systems function in other countries differs from the United States. Maybe we don't have it figured out, but we decided that we're the standard of care, and so if we go into these countries and try and perform medicine the way we do it here, this can harm patients. Moving on, it can also be an over-reliance on foreign aid, which might sound a little bit weird considering volunteering is seemingly an altruistic activity. But if done inappropriately, providing aid through international medical volunteering can subvert established healthcare systems in these countries, because when you're offering care for free to these patients, more than often these patients are going to elect to get care from the volunteers rather than the established healthcare institutions in the country, which removes patients from these organizations, and the governments of these countries may decide, hey, we don't need these hospitals anymore. And so they'll close down hospitals, and this will add additional burden onto these volunteering organizations, which will increase demand for people in the United States, and there might be more spots for us, but the healthcare system in these countries will suffer. Next, there's also an issue I like to call displaced patient care. In order for these international medical volunteering initiatives to secure a spot in these countries, they have to come to a diplomatic agreement with the country that they're staying in. And so oftentimes the consideration that these companies must make is what places are safe to go to. After all, you have kids like me who are traveling on these expeditions, and they want to keep us safe so they don't get sanctioned by any kind of lawyer or anything like that. There will something to go wrong. And so oftentimes these international medical volunteering organizations will resort to providing care in regions that still need care, but they're not as desperately needed as rural regions. And the best way I can kind of draw a comparison to this is if you imagine the United States needing foreign aid in healthcare. If some foreign country decided to enter the United States and only provide care in the biggest cities in the United States, like New York or Los Angeles, this leaves a lot of territory in the rural regions of the United States, which even right now don't have access to quality care. And so this was another takeaway I got from my experience in Guatemala, that there are a lot of issues that there are more extreme issues in Guatemala, but we kind of suffer from the same issues in the United States as well. The last issue I want to point out is insufficient training. And this one's pretty obvious as well. If you have students, pre-medical students, high schoolers, or even medical students who aren't equipped with the necessary skills, whether it's the medical term or the medical knowledge or the linguistic capabilities or the cultural knowledge, this can also cause harm. And that's kind of overlaps with everything for us. And so now you might be wondering, how can we address these problems? The easiest thing that we can do is implement culturally competent care protocols. And this can mean anything from having students learn about the culture of the country where they're traveling to. This reinforces a lot of global health practice, as well as training people to speak the language. When I was in Guatemala, I practiced a lot of Spanish, thinking I was going to be speaking Spanish, but to my surprise, Guatemala is just as diverse as the United States, and people there don't necessarily speak Spanish. many of our patients were indigenous, members of the indigenous communities that we served in, and even the physicians needed interpreters in order to be able to provide care. And so if I had known that before I went there, then maybe I don't know if I could have learned enough to actually make a difference, but still this is something that we should consider. The next thing that we can do is involve the community. And this can look different, this can be applied differently in many different ways. This can be recruiting community physicians, nurses, interpreters even, into working for your initiative. And this does two things for your global medical volunteering experience. It not only provides an opportunity for these workers to be compensated, which to a lesser extent alleviates some poverty, but not so much, but it also enables us to develop trust with the communities that we're working in, because they'll be receiving care from people who belong to the communities that they work in. And so this might make patients more comfortable to receive care from you, and there might be a little bit less suspicion about, okay, are you really taking advantage of me, or are you just here to actually do what you said you're going to do? The last thing that we can do is commit to sustained aid and community development. And this might sound like it conflicts with my previous statement about how we can undermine healthcare if we're not careful. But sustained aid, just like rigorous, or just like involving community, excuse me, I skipped over something, I'll get back to that. But community sustained aid enables us to also continue to develop trust. And then community development also allows us to lead these communities better than we found them. Going back to rigorous volunteer selection, this also addresses the last issue I pointed out on my last slide, where we can select volunteers who not only have the skills to provide medical care, but also who are knowledgeable of their privilege and the position and the influence that they have on these communities. And if we take care of these issues, then I think we can have a better global medical volunteering model that will improve not only how we provide care and how the experience of the volunteers goes, but also the kind of care that patients receive. So, thank you.
Hi everyone, my name is Raghav. I'm a neuroscience major and a philosophy minor. And I did my project on direct-to-consumer genetic testing and how that is influencing the sperm donation industry, especially in regards to anonymity. So as you guys have all known, especially from Francis's presentation, genetic testing is really taking hold of the consumer market right now. And in the past 10 to 20 years, both the availability to consumers and the technological advancements have made it really become popular among people. And now I think for 23andMe, you can get a very accurate genetic test for less than $70, which, 20 years ago was just outrageous to expect, and the power of that technology is truly amazing. But for sperm donation, something in which people rely on being held anonymous and are guaranteed anonymity, this has drastic implications. As you can see on the right, one of the most popular features of most genetic testing, especially like 23andMe and Ancestry.com, is creating these family trees that have surprising accuracy in constructing a tree of who your possible biological ancestors are, which can be a very attractive proposition for people who have biologically ambiguous ancestors. In 2018, there was a woman named Danielle Tusher who bought her child, who was a product of genetic test, or who was a product of donor insemination. She bought her daughter a genetic test and used it, and was able to track down the father actually. And online, she went to the mother and asked the mother if she would be open to communication. And what she received was threats of a restraining order, a $20,000 fine, and the clinic threatening to take her samples that she had previously bought and was planning on using for future children. So clearly there's this huge miscommunication and gap in the system between how the clinics and the state's legislation is structured, whereas the information that donors, donor recipients, and donor-conceived children are receiving. So in this survey from 2019, you can see that 55% of people who were able to 55% of donor-conceived people who were able to successfully identify their donor did it through genetic testing, which really shows you how accurate and powerful this technology is. But the system that we use is not catching up to this. We're not changing our legislation to accommodate these new changes. Recently, the biggest change to this was Colorado, which recently passed a law that banned anonymity, which won't take effect till 2025. But currently, 49 of the other states still allow anonymity to be guaranteed, including California. So donors across the country right now are still being told that their anonymity can be guaranteed, even though, as we know, it's clearly not. So I think when I started this project, I kind of thought I was going to run into these huge, multifaceted, really complex issues regarding anonymity. But I think it really is a basic and shocking ethical problem that we're facing right now. Donors are essentially being lied to and are being withheld information about how their identity can be revealed, despite the fact that we know they can be easily tracked down. So what are the future directions? Obviously, first, all 50 states must ban anonymity. We can't have this keep going on because the donors' and autonomy is being violated drastically. So for donors, I think we first must educate them on what can happen with their information once they donate their specimen. Even though their information might not be shared by the clinics to the donors or donor recipients, it's definitely clear that they should be told that their information is available on a lot of genetic databases and they may be able to be tracked down. Donor-conceived children are another stakeholder in this with a surprisingly small amount of autonomy. They had no choice in whether they want to be a donor-conceived child or not. And often these people feel that they want to be connected to their biological paths. So I think to protect both of those communities, what we must do right now is switch to a system in which donors have their information shared with their children at the age of 18. And whether children want to contact them or not is up to them, but donors have to be fine with the fact that that may happen. The biggest counter-argument to this that people will still use is that donor-seeking parents who want donors to create children, might have less accessibility to this if we switch to a non-anonymous donor situation, or donor system, which is completely true. I think a lot of donors express that they wouldn't donate if not for being guaranteed in anonymity. But I think this is completely irrelevant to the ethics at stake, because this is arguing that we bypass the ethics for the pragmatism of having more donor specimen, which to me is completely ethical. We can't just break someone's autonomy and lie to them just for the sake of receiving more samples. I do think that's a real problem, and I think the way that we can change that is through a slow but gradual cultural change regarding anonymity and donor, just the entire way donation works in this country. Right now there's a lot of stigma around it. People don't like to talk about it. People don't tell their children about it. Some people go their entire lives without knowing it. And I think that also really benefits donor-conceived children. We're taking away the stigma from them. We're allowing them to be part of a community that is proud of their biological origins. And we're best facilitating these interactions between the donor-conceived children and the donors that is really inevitable to happen right now. Thank you.
Thank you.
Hi everyone, I'm Caitlin. I'm a junior neuroscience major, and I'm going to be talking about the ethical debate on death and fertility. So, as many of you may know, or might be able to guess, any form of physician-assisted death or suicide, now referred to as medical aid in dying, or MAID, has long been stigmatized. Even the American Medical Association opposed it for many, many years, and only just recently, and very carefully, affirmed the physician's ability to perform medical aid in dying within the limits of their conscience. However, medical aid in dying is a really important end-of-life care option for patients who have run out of other options. So, just to provide a quick definition of medical aid in dying, MAID is the medical procedure and legal right of terminally ill patients receiving physician-prescribed and provided medications to end their lives. MAID is distinctly separate from euthanasia, which is the act of someone else administering medications to a patient to end their lives. Currently, there are only 11 U.S. jurisdictions, which you can see here, that allow for medical aid in dying. This is a great first step, but many of these states have impractical and unethical restrictions on the ways in which MAID occur. Which brings me to the two main ethical issues that I'm going to talk about today. The first being that some people believe, understandably, that physicians performing medical aid in dying is a violation of the ethical principle of non-maleficence. And the second is that the current MAID law here in California is unethical not because it allows access to MAID, but because it is too restrictive. So, to touch on the first, it's a physician's ethical and moral obligation to provide the best care that they can to their patients and to do no harm. We've probably all heard the phrase, do no harm, Hippocratic Oath. It's one of the major tenets of being a physician. So if a patient desires medical aid in dying, that means their physician has to provide them with the medications to do that. And so the question that physicians face is, does doing that violate the ethical principle and obligation of non-maleficence? And there are plenty of people who would argue that, yes, of course it does. It's morally incompatible with a physician's role as a healer, and that allowing physicians to do so will not only harm patients, but will also lead to physicians becoming lacking in compassion. However, and I know this from personal experience, for some patients, no amount of pain management can ease their suffering. So I would argue that it is more in line with the principles of beneficence and non-maleficence to prevent future physical and emotional harm and suffering to the patient. Additionally, when patients are terminally ill, it's also really difficult for their families. Of course, the patient is the one with the illness, but there's something to be said about watching your loved one's condition deteriorate, knowing that there's nothing you can do about it. So by letting people die with dignity in the place and time and manner that they desire, we are not only respecting their right to autonomy, we're also giving them back a choice in a situation over which they already have so little control. So moving on to the next concern. There are so many ethical concerns around allowing MAID that I could talk about that almost all day. But right now I want to talk about California's MAID law. So the California End-of-Life Option Act requires that any patient who desires medical aid in dying has a terminal illness, a prognosis of 6 months or less, be at full mental capacity, file several requests for MAID with plenty of waiting periods in between, and most importantly, they need to be able to physically self-administer their medications. So that means either they need to be able to sip through a straw and swallow, or they need to be able to physically push a syringe to administer it through a feeding tube, for example. So what that means is that these requirements are in place as a medical safeguard to prevent abuse against vulnerable populations. Because there were and are fears that if we allow clinicians to administer it to patients as it is allowed in other countries, that vulnerable people who are not able to speak up for themselves may be taken advantage of. However, I would argue that this requirement does more harm than good because it discriminates against people with specific illnesses. For people with neurological disorders, for example, especially ones that are progressive like multiple sclerosis, Lou Gehrig's disease, or Parkinson's disease, this requirement limits their options for end-of-life care. They either have to choose to pursue MAID, possibly sooner than they are ready, but while they still have physical motor functions so they can self-administer their medications. Or they risk waiting and possibly losing their physical motor function and eligibility for MAID. Tough choices in a world of what is already full of tough choices. I believe that this requirement violates not only the American Disabilities Act, which mandates equal access for health care, it also violates the ethical principle for justice, because people with neurological disorders are made to bear an undue burden compared to those with other terminal illnesses, and they're not getting what is their due, which is equal access to health care. So, moving forward, it's clear that there are plenty of complexities surrounding MAID. Whether to allow it or not, it's really difficult to draw these lines, especially because euthanasia is so stigmatized, but until MAE is accepted as a proper part of healthcare, patients are going to continue suffering from a lack of knowledge and research about MAE because of the stigma. So, in addition to educating patients and providers and the general public about medical aid in dying, we should also reform our laws to allow equal access to medical aid in dying for all, because it's not fair to discriminate against someone because of their disability, their illness, and their cause.
All right. Hello, my name's Claire. I'm a biology and dance double major, and we're going to segue a little bit. And I'm going to discuss the ugly side of competitive dance. So thank you to Dorothée and the Markkula Center for letting me look at a different side of healthcare through competitive dance. That's where my background is in, and I'm just really excited to look at it. So starting off, what is competitive dance? So the basics. Competitive dance are based on a sport-like competition where dancers perform in front of judges to receive accolades, so awards or recognition within the dance community. And there are positives to competitive dance. For individuals within it, you gain a lot personally. So you gain a lot of work ethic. You gain competition skills, which include teamwork, as well as the confidence to get on stage and show what you've got. But there are also some serious harmful consequences. These competitions are put on by private companies around the US, and they create competition circuits which travel around. These competitions usually, they have around 80 regional competitions and 6 national competitions, and they'll have around 1,000 acts in each one. So tons of people are involved in this, and a lot of dance studios attend and bring their dancers there. But along with this, there are a bunch of negative consequences as well. And I'm only going to go into 2 in depth today, but there are plenty more. If you are ever curious, you can come talk to me. But the first is negative body imagery. This begins from the ballet world, where the idealized body came from within dance. George Balanchine, back in the early 1900s, created this stereotype for dancers. And we're still stuck with that today. Although progress is being made, we have not escaped it. So dancers are meant to be slim. They're meant to have long limbs, long legs, long arms, slender necks, and also conventionally attractive faces. But with that, the media is still pervasively spreading this imagery. And though we see some dancers who break this stereotype, Misty Copeland, the very famous one, it is still seen, and dancers are still rewarded when they have this particular body type. And this is also very present within the competitive dance world. So it's been taken out of ballet and spread everywhere. The second reason is through sexualization of these dancers. In the image I have on the screen, this was a very famous image within the dance community in 2009. The dance title is My Boyfriend's Back, and as you can see, these dancers, who are between 8 to 10 years old, are in these bra tops and short shorts. They dance very suggestively, and they also have facial expressions that seem to say, oh, like my boyfriend's coming home, I want him to come home. That's the best way I can describe it. But this created a big wave in the dance community because we started realizing, why is this happening? And it turns out there are no practices or rules set in place for studios to stop it. Within the dance world, both competitions and studios do not have set rules and regulations. They do whatever they want, and though some studios are very good about it, some studios are not. So it really depends on where these dancers end up attending. Training practices also help stereotype these negative body images for dancers. First, through the studio layout. So if you go into a dance studio, you'll see these large mirrors on the front of the room, sometimes multiple sides of the rooms with ballet bars. And you are expected to look at yourself in the mirror the entire time of that class and constantly critique yourself. Which, as you can imagine, if you're doing that for days on end, hours on end, you will start to associate only the negative parts of yourself with your own self-image. You start looking at the little finger that's out of place, or how you have a little bit more width on your leg compared to other dancers. And that's really what you keep focusing on. Teacher corrections also come into play. This is also, it started with ballet and it spread to competitive dance. One common comment is, I can see your lunch. If someone's standing at the bar and practicing, the dancers could use more direct tips. What they really mean to say is you need to pull up through your spine, put your head back, stand up tall, but they choose not to. They choose to associate these words that combine body imagery with food, and that creates really negative associations that stick with dancers later in life. And there's also a lack of autonomy. because the people who are saying this to these dancers are people in a place of power. If you have teachers and directors who are telling you that you need to change parts of yourself, you're going to take that to heart. And it's really difficult when you start at the age of 5 and you're brought up with that throughout your life. So competition dancers are very vulnerable to negative body imagery. It's also seen that they have low self-esteem and disordered eating throughout life. That's not to say that every dancer goes through this, but it is very prevalent within the dance community. The second is an unnecessary injury. And this is seen once again through a search for aesthetics within the dance community. The one that I'd like to focus on is flexibility. So as you can see here, the dancer has one leg placed on a chair and the other one behind them. The goal is to get your legs past 180 degrees, which is not normal for your hips to do. And you will see some teachers at certain points actually pushing down on these dancers, which does cause harm in the moment and also long-term harm on the muscles and joints. So a search for extreme flexibility is one example of this, and there are tons of training practices that create a similar scenario for dancers. Overuse injuries are the most common injury for dancers. This is done through when you're learning routines, you do one part of that dance about 100 times in a row. You're going to get it together with your group, and you're going to know it by heart. But when you don't have time for rest and you don't have time to take a break from that, you're going to develop these overuse injuries. There's a lack of preventative care within the dance community. It's very common for studios to kind of forget about that aspect. If you have 1 hour with your dancers, you're not going to spend time on talking about nutrition, what they should have in their diet, what they shouldn't, what they need to worry about, what they don't need to, how they can cross-train, how they can do all of these things, how important it is to warm up before you start dancing. And you only learn about it until you do the research yourself. So an expectation of dancing through the pain is very prevalent in the dance community. I was a competition dancer throughout my time growing up, and I was very blind to the ugly side of this world. It was only once I graduated and talked with other fellow ex-competitive dancers that I realized all of the struggles that we felt all together. It's very communal in that. And there are some funny things. We share stories about having nightmares about forgetting a costume or not making it on stage on time. But there are also things that stick with you beyond that. There's a constant self-criticism that happens. You're always searching for perfection. Those are just 2 examples. Once again, not for everyone, but a lot of dancers that I talk with. So this is just one example of what can happen. But now it's time to move forward. So within the competition dance world, there are a lot of potential benefits. It's just a matter of fixing things and changing things in this moment. It's time for immediate change in order to find a positive and collaborative, helpful environment for these competitive dancers. And this is going to be done through 3 avenues. First, we have the studios. It's essential that studios update their rules and guidelines so that dancers have a safe space where they can go and tell the teachers or directors what they need to. This safe dance space is a place where dancers can go without fear of harm or consequence. So if a dancer is scared to tell someone about their mental health concerns or their physical health, then we haven't created that safe space yet. And that's where a lot of studios are today. But if we increase that and we're able to get to a space where teachers have training on what mental health crises look like with dancers, how they can assist them, how to make those direct teaching tips and avoid these flexibility practices that we mentioned earlier, that's going to be a big step forward. The other 2 are dependent on that, but first we have parents. Parents need to get involved in their dance students' education. So for their children, it's really important to ask questions and state their concerns. That can be really difficult because as a parent, you're coming in from the outside. If a teacher acts like they know what they're doing and they know what's best, it is very difficult for a parent to say their concerns. But for the better of their own child going through that process, it is really, really essential. For students, this one's the most difficult, but it's really important to trust yourself and speak up. If something's happening in the studio that you don't think is right, it's really important to be able to say that. And if it's not a comfortable space to do that within your own studio, it's important to do that within your own family. And then you can go from there. But I just wanted to give everyone a little bit of a background on the competitive dance world and some of the problems within it, because it is very prevalent, but you don't know about it unless you're in it. So thank you very much.
So my name is Renzi Flojo. I'm a senior bioengineering major on the pre-med track. But my major clinical experience has been primarily dealing with elderly care and especially with those experiencing Alzheimer's. So this is a very close to home. This is kind of my passion and something I've explored throughout my time at Santa Clara. I would love to share it with you all. Cool. So who in this room, kind of give a show of hands, has either like known a person who has Alzheimer's or dementia, or has like family members, or just heard stories? Hands. Well, we see a lot of people who personally been touched or experienced, or at least have heard stories and kind of have an understanding of this. But about 10% of the whole U.S. population has this disease, and it's only increasing as time goes on. And there's major social barriers that have been hampering its diagnosis and treatment, and are just impeding the sources of care. But just broadly, so I know that everyone kind of knows, Alzheimer's is just a neurodegenerative disorder that kind of is associated with a whole host of symptoms. So the main one is memory loss, and that's kind of the big concern, especially in terms of an ethics standpoint, because it kind of hinders the autonomy aspect that we all love and preach about. Just because, can you imagine you're missing bits and pieces of your whole memory, and who are you? Are you yourself with Alzheimer's, or are you yourself without? And that kind of brings up this whole metaphysical question that I don't really want to delve into, because not many people have fully fleshed out that concept. But I know that with autonomy, the major two parts that's affected with Alzheimer's care, especially, is the medical aid in dying, as Caitlin has mentioned, and especially in advanced directives. So I'll kind of be touching a bit about the both, as mentioned by Caitlin, that one of the requirements for medical aid in dying is the ability to be like an autonomous person, to be able to understand what you're going through and have the intention behind your actions. But as mentioned by primarily the symptoms of memory loss, that you really don't have that, and it is debatable within Alzheimer's patients if they even do. But I do agree that I think we need to expand medical aid in dying to include this patient population, and hopefully we'll be able to see that moving forward, but that's definitely a major step that needs to be changed within the medical system. But primarily, I'm going to be touching upon advanced directives. How many people in this room are above 18? Raise your hands. Cool. How many people in this room have an advanced directive? Keep your hands raised. Okay, cool. I should be seeing everyone besides Charles to raise their hands. So if you take anything from my talk, I would really just want you to begin the conversation with your PCP to maybe start thinking about an advanced directive, because no time is better like the present, because you only ever need it when you're really in the trenches and not really healthy. But it's good to have that conversation when you're fully healthy. But so the primary concerns, especially with an advanced directive in terms of Alzheimer's care, is that the directives only enable a refusal of care. So that kind of allows for, if there's a current option of treatment, you can refuse it. But it doesn't let the option, especially in terms of medical aid in dying, it doesn't allow that option for taking treatments that would actively reduce the life living with Alzheimer's, because it's definitely scary, because there's no typical cure for Alzheimer's. You're when you're diagnosed, it's just the life expectancy is about 8 years on average. So some people rather call it early, sad to say, but they rather not have a life with just essentially not themselves, because they're more afraid of living a life with Alzheimer's and not be themselves, as opposed to a life with Alzheimer's and just their new reality, essentially. And then also, it's ambiguous if directives should be respected, especially in Alzheimer's care, because it's the whole metaphysical problem of, should you trust something that you yourself, pre-Alzheimer's, should be trusted for the care that you have post-Alzheimer's or during Alzheimer's, essentially. But ultimately, we need a better system for having an Alzheimer's and dementia-specific advanced directive that values the value of autonomy. I'll kind of go into the traditional aspects. So the traditional two types of advanced directives are the DPOA, so the durable power of attorney, and the other option is the living will. So the living will is kind of like where you just jot down your ideas, like, I want this to be done, and I want this to be done. But the durable power of attorney is kind of you elect a proxy. So usually it would be like either a spouse, a family member, or like a caregiver, something you're really like close to and you trust. So in my case, I would probably do my mom or my girlfriend, but probably it would be someone you really trust to enact your medical care. But we do have two non-traditional options that are kind of being looked in circulation. So the most recent one is the Dartmouth Dementia Directive. That kind of enables this differentiation between the three different stages within Alzheimer's disease. So Alzheimer's is kind of broken up to mild, like the average, and then severe. So the severe, you kind of have incontinence, inability to move, and then more frequent changes within like your mood. But you're able to state what you want. You're able to state your medical like care goals. You're able to state your drinking, your feeding goals, and then also your living goals. So you could say like, suppose that once you hit like mid or like mild Alzheimer's, you would only want like comfort care, or if you would only want to be able to live within the house as opposed to living within like the hospice system or even in like a skilled nursing facility. But also a new avenue that's being looked into is the communications approach with the Stanford Letter Project. So the Stanford Letter Project kind of is just a rechecking of value system. So it's essentially, it's a letter. It's essentially just a letter to your doctor saying, and just stating your your goals for your care and everything you hold dear. And this can be rechecked at every like doctor visit. It can be done through a PCP. But that's also seeing if it can be replaced as like an advanced directive. But all of these like potential solutions need to be brought up into like the common clinical space as like the next step. But as a nice beginner step, as I kind of have the crowd now, is to at least have your PCP talk to them about like having an advanced directive, and know, especially advocating for those with Alzheimer's and those you know, to like have an advanced directive for it as well. Thank you so much.
Hi, my name is Kyla Nunez-O'Leary. I'm a current senior at Santa Clara. I have a major in public health science and minors in biology and Spanish. During the COVID-19 pandemic, physicians and patients were forced to find new ways to connect with one another. Women's health was not unique in this manner, and it was unique in one specific way. Women's health is often overly politicized and found to be a contentious issue within the United States especially. But during the COVID-19 pandemic, people's political gazes shifted away from women's health and toward things that were affecting them daily, like mask mandates, vaccination rollouts, and stay-at-home orders. During this time frame, women's health scientists and doctors were able to go ahead and continue on the process that they've been working on for decades without people's political opinions standing in the way of what they wanted to do for their patients. We saw this in huge choices for people to make signs that said things like "My body, my choice." It had to do with no mandatory masks. And these were also used in women's marches when people were fighting for the right to choose. Overall, telemedicine was one of the biggest things that helped people make connections with their physicians during the COVID-19 pandemic, and women's health wasn't unique in that manner either. Things like medical abortions, which is an abortion that happens with pills and not a surgical procedure, happened over telemedicine. People were able to take these two pills, misoprostol and mifepristone, in their own homes after having a telemedicine visit with their doctor, screening out any issues to make sure that this would be a safe and healthy procedure for them, and giving them the right to choose within their own home. Women were no longer asked to go into clinics where they may face hostile protesters, people that could throw things at them, yell at them, for simply entering to a clinic, regardless of their reasoning. People were no longer asked to sit in waiting rooms. They were no longer asked to sit in sterile exam rooms. They were no longer asked to risk being seen by family, coworkers, friends, or peers that may retaliate against them for entering into one of these clinics. clinics. They were able to do this from the comfort of their own homes, in their bedrooms, secure appointments to their physicians. This is something that would not have been able to happen without the COVID-19 pandemic. While medical abortions have been something that has been processed in the United States and throughout the entire world, especially starting in countries where women do not have access to abortions due to the legislative rules of their governments, telemedicine was a big jump. Even doctors were worried about this. They thought, we're going to have a lot of cases that are going to go really south really quickly. And to their surprise, that didn't happen. Efficacy rates were found to be exactly the same as in-clinic medical abortions. Gestation rates were actually found to be earlier. Women were getting into the doctor sooner. Complication rates were the same. People were coming out with the same exact results as they would in clinic. And it was saving time, money, and people trips to the doctor's office. So, looking at this, it came out as a huge win. People were excited. People were ready for this to be a big stride in women's health, especially without having to deal with all of the contention that usually comes along with abortion issues. Looking from the physician perspective, physicians were finding that this not only created quicker appointments with patients, they were also seeing less delays, less cancellations, and oftentimes more success rates with folks that were coming in at earlier gestational ages and less likely to miss ectopic pregnancy, which often happened when people were waiting out time because they didn't want to go to the clinic. Patients found that it was easier for them to also access their physician. They were able to make an appointment online, have an hour to themselves. There was no taking off of work. There was no driving the 20, 40-hour-long drive to your physician, but instead it was right in their home or wherever they had access to secure internet. And so in 2020, the CDC found that the highest percentage of abortions were performed at early gestational ages, and that was up to 51% of abortions. That means that 51% of abortions could have been performed via telemedicine. But it's not to say that that should be the case. One of the critiques with this is that telemedicine, after pandemic, where we all spent so much time apart, is forcing people to also have that experience once again with their physician. But that's not the case. This is only to supplement those in-person meetings with physicians. Women should obviously have the right to go in and see their doctor, talk in the clinic if that's what they desire, but they shouldn't be forced to do that either. So while people think that this may interrupt the physician-patient relationship, it may also develop it more because if the patient is in a more comfortable place and the physician is also more comfortable with the situation. Now, with these large strides, we also saw really big setbacks. The Dobbs decision has been mentioned here multiple times tonight, and I think it's because it's something that's incredibly charged. It's something that almost everyone, every woman that I know felt, whether it was one way or the other. Some people were in incredible support of the Dobbs decision, which overturned women's right to an abortion and to privacy, which we can see in that first photo where people are saying goodbye, Roe. This is the pro-life generation. And then we also see in the second photo that the UN said that forced pregnancy is a crime against humanity. And so there are these two incredibly charged sides of women who are just fighting for their rights. People who are fighting for patient autonomy, people who are fighting for justice in communities where they do not have access to normal OBGYN care, they do not have access to the funds that they would need to raise children because of structural inequalities. And so something that's cropped up has been these pill fairies. Pill fairies are communities of people, whether they are organizationalized as an allied aid, as a company that does this, or individual women, like a 76-year-old woman who appeared on an NPR podcast and talked about her work doing this. But they send out these two medications to women in need after they've taken the electronic quiz online that's reviewed by a doctor. So oftentimes, women will go in and take this quiz, and those same efficacy rates are found. Same complication rates, same risk rates. Everything is exactly the same. And it's less risky than a surgical procedure, which is what most people think about when they think of abortion. So getting in at this early gestational age and being able to do it online with the internet has provided this huge avenue for women, and it's only made possible by communities of people that are surrounding them, uplifting them, saying, no, you deserve a right to patient autonomy. You deserve a right to decide what you want to do with your life. And this is something that's vital and needs to continue, and would only have happened with telemedicine and the pandemic. But that's not to say that this isn't without its problems. 77 million people in the United States do not have access to consistent, secure internet. Now, when we think of the pandemic, we think about everything going online. Work, social structures, school, play, any type of interaction that you would have with people who were not in your household was going to be online. 77 million Americans could not experience that. These 77 million Americans are disproportionately recognized as Black, Latino, African American, and Indigenous peoples. All of these folks together also make up the communities of folks that are less likely to have access to in-person OBGYN care. Rural communities, communities of low socioeconomic status, and Indigenous communities are found to have the least access to this care. So what does that mean for them? They are less likely to have access to in-person care, and they are less likely to have access to the telemedicine solution that we've also found. And on top of that, during the pandemic, which made these rulings possible, these folks also made up the majority of people who were essential workers, people that were asked to show up at work, that were asked to do shift work, services that kept all of us alive, people that continued to carry out our garbage every weekend, people that continued to work in restaurants with masks on, delivering out food, people that brought your DoorDash to your door when you didn't want to go into a restaurant. These are the same folks that don't have access to the healthcare. They don't have access to the things that were really created out of COVID. So these solutions that we found, like telemedicine, were the things that these folks didn't have access to. And so that's where we see this big structural inequality and where this really becomes a justice issue more than anything. This has been a very long fight. This is not a new issue. Women have been asking for rights in this country and in countries all over the world for a very long time. Telemedicine abortions is a huge step. It is a huge way for doctors to continue performing no-touch abortions with the most amount of access to the most amount of patients that desire this care. And it's not only a no-touch abortion, it's a conversation about what you would like to do next. It's a conversation about what you actually have access to, what your resources are. My argument is that people should have autonomy over their care. And if the internet provides that, then the internet becomes a public health good. Public health good like clean water, like housing, like education. It's something that we need to survive. If you can think about the last time that you didn't use the internet for an entire day, whether it was to Google Maps your way here today, whether it was to look up a quick answer to something that you needed to know, imagine not having that. And imagine not being able to ask your doctor a question either. I say that what we need to do is work for health equity. Health equity is going to be our biggest winner here. Health equity means equity for women that are not only in states that protect them, even with the Dobbs decision coming down. It's not only for women with internet access. It's not only for women who do have access to a primary care physician that they see on an annual basis. But it's for women everywhere. And so moving forward, ethics can't be our closing statement. Ethics can't be the reason why we say, yes, this should still stand. Yes, people still should be able to have no-touch abortions via telemedicine. Why? Because it's ethical, because people have personal autonomy over their healthcare decisions. It has to be the opening. It has to be the reason why we say, no, we need to make more changes so that more people can access this, so more people can talk with their physicians. Because there's 77 million people that are serving us, that are in communities that are rural, that are far away, that we don't think about in our big cities, are the people that also deserve care just as much as you or I. Thank you so much.
Oh, thank you so much, everyone. This is the end of our symposium, of our inaugural symposium. As I mentioned, it was the first one hosted by the Markkula Center. And I have a couple of things to say tonight. I know we have been all incredibly patient, so thank you so much for that. I know it's a very long event. And I wanted to share something very dear to my heart. How many of you know this book? The title is Very Good Lives. I knew about it. No one knows about it. And yet, this is written by J.K. Rowling, that you all know, certainly, thanks to her best-selling Harry Potter series of 7 books, right? And I'm sure most of you have read, those books from Harry Potter. I haven't, I admit, but I've read this one. And this one is actually the best one she wrote, in my opinion. And that's the reason why I wanted to share it with you. And what she says at the back of this book is exactly this. We do not need magic to transform our world. We carry all the power we need inside ourselves already. And I would like to read just one page. I know I have a very strong French accent, so please forgive me in advance if you don't understand everything I say. So, she said, to young students like you who are about to graduate from whatever studies they were doing, she said, if you choose to use your status and influence to raise your voice on behalf of those who have no voice, if you choose to identify not only with the powerful, but also with the powerless, if you retain the ability to imagine yourself into the lives of those who do not have your advantages, then it will not only be your proud families who celebrate your existence, but thousands and millions of people whose reality, you have helped change. You do not need magic to transform our world. We carry all the power we need inside ourselves already. We have the power to imagine better. And so my wish and my blessing for each one of you guys moving forward to your fantastic careers and future is that you have the power to imagine better, but also to do better than we have done us as previous generations. Because the world needs you, and I know you will do it. Thank you so much.